Go ahead and open up the hearing for House Bill 2556, expanding Medicaid assistance eligibility and enacting the cutting health care costs for all Kansans, for the Kansas Act, for all Kansans Act. I will lay out the rules of the committee. No signs, no talking, no noise, no clapping, 0 from the audience, no disparaging committee members, staff, or the legislature. Should you decide to do so, you will be asked to leave the room. And should you choose not to leave, then you will be escorted from the room for trespassing. So at this time here, I'm going to have Revisor Moyer give us a brief explanation of the bill.
Thank you, Madam Chair, members of the committee. House Bill 2556 expands medical assistance eligibility and enacts the Cutting Healthcare Costs for All Kansans Act. I will do a brief explanation of the bill and not go into detail on all of the 23 sections of the bill, but I'll be happy to answer questions if there are any. Section 1 names the act, and in that section, the legislature expressly consents to expansion of Medicaid eligibility. It gives the Secretary of Health and Environment authority to adopt rules and regulations to implement and administer the act. Section 2 would require the Secretary to seek approvals necessary to implement the act from the United States Centers for Medicaid and Medicare Services, as well as the State Finance Council. Section 3 would require the Secretary to require applicants for coverage under the act to provide employment verification, and goes into what qualifies as employment verification. Section 4 allows the Secretary to establish a health insurance premium assistance program. Section 5 would require the Secretary to administer the program using a managed care delivery system. Section 6 would terminate coverage under the Act over the course of 12 months if the federal Medicaid assistance percentage, which we call FMAP, match becomes lower than 90%. And Section 7 is a non-severability clause, which is the opposite of a severability clause that we've dealt with before, establishing that if the provisions of Section 6 with that 90% FMAP coverage are not approved by CMS, then the act would be null and void. Section 8 deals with a report beginning in 2026 regarding cost savings. Section 9 would require coordination between the Secretary of Corrections and KDHE, and to work with sheriff's departments regarding the facilitating coverage for individuals in a county jail or correctional facility. Section 10 would require a report to certain legislative committees regarding cost savings from the bill. Section 11 deals with drug rebates from enrollees, and the entire amount of those drug rebates would be transmitted to the State General Fund. Section 12 establishes the Rural Health Advisory Committee, which would be a 15-member body comprised of individuals representing a variety of industries and individuals. The committee would be tasked with developing methods to identify individuals who are underserved by rural healthcare system and recommending approaches to rural healthcare issues to the governor and other state agencies, and they would also be providing a report beginning in 2025. Section 13 prohibits the act from providing coverage for abortion services unless that is required by federal law. Section 14 amends the statute that develops the Bob Bethel Joint Committee on Home and Community-Based Services and CanCare Oversight. It would amend that statute to meet for one additional day during 2025 and 2026 to monitor implementation of the act. Section 15 amends KSA 402313 relating to the privilege fee paid by health maintenance organizations. It strikes outdated language regarding the amount of the fee and clarifies that it would be a 5.77% privilege fee amount. Section 16 amends the annual hospital Medicaid expansion surcharge definition and assessment revenues definition. It adds those two. Definitions to that statute and would require the Secretary to receive approval for that Medicaid expansion surcharge. And most of the remainder of the sections, section 17, 18, 19, 20, and 21, relate to that Medicaid, the hospital Medicaid expansion support surcharge, establishing it, making references when it's payable, establishing notice. And then the last two sections of the bill, KSA 65, 6217, and 6218, relate to the Healthcare Access Improvement Fund and the Healthcare Access Improvement Panel, which would be tasked with approval of surcharge revenues. And I'll be happy to answer questions.
Questions for the revisor? Jen, I just have a couple. If I understand correctly, the FMAP is for 2 years. Is that correct? The enhancement of 5%?
So the federal medical assistance percentage is established by federal law. The 5% increase is not established in the bill. What's in the bill is just if it goes below 90%, the act is null and void.
Okay, and then somehow I'm not finding it in here just because I'm skimming it so fast. The hospital surcharge is, how much is that?
The hospital surcharge, let's see, the HMO one is the 5.77%, and then the...
How much was that again?
It's the current law, it's the cleanup in section 15. It would be 5.77% of all total premiums. And then... And then the annual hospital Medicaid expansion surcharge is the product of the number of unduplicated Medicaid expansion enrollees multiplied by $233, which is on page 12 in section 16.
We were having trouble with speakers outside the room, so I'm sorry.
No problem.
So we have the HMO at 5.77, and what's the other one?
The annual hospital Medicaid expansion surcharge is the product of the number of unduplicated Medicaid expansion enrollees multiplied by $233.
All right, committee, is there further questions of Revisor Moyer? All right, seeing none, thank you very much, Jenna. All right, the first oral conferee that I have is Christine Osterlin, Deputy Secretary for Agency Integration and Medicaid, Kansas Department of Health and Environment. And all of our proponents, because of the quantity we're dealing with, will have 3 minutes. So welcome to committee.
Okay.
Christina.
Good afternoon, Ms. Chairwoman and members of the committee. My name is Christine Osterlin. I'm Deputy Secretary of Agency Integration and the State Medicaid Director for the Kansas Department of Health and Environment. I'm very pleased to speak to you this afternoon about Medicaid expansion. First of all, I want to talk a little bit about what is Medicaid expansion. To kind of get the perspective, we need to talk a little bit about the current program. Currently in Medicaid, as an adult, to be eligible for Medicaid, you must be very low income, but you also must fit into one of 4 categories. You must be an adult and disabled according to the Social Security Administration. You must be an adult and elderly, pregnant, or a parent or legal guardian of a minor child. The income threshold currently for adults in Kansas to qualify for Medicaid is 38% of the federal poverty level. What does that mean? What that means, if I'm a single parent with 1 child, I am limited to only make $648 a month or $7,776 annually in order to qualify for Medicaid. If I make above that, I do not qualify. Medicaid expansion, as contained in the Affordable Care Act, allows the state the opportunity to increase enrollment up to 138% of the federal poverty level while getting rid of those categorical requirements. So let's talk a little bit about what does 138% of federal poverty look like. That means that that same single parent with 1 child can make $2,351 a month or $28,212 annually. I would submit to you that making $28,000 a year with a child dependent when you're paying for rent and other expenses is still extremely low income. Who else does the Medicaid expansion assist? And there's been talk about able-bodied adults, but it's broader than that. Who else does it help? Right now, we have individuals on the home and community-based services wait list. 70% of those are eligible for Medicaid. That means while they're waiting for a waiver slot, they are receiving Medicaid services to help treat their numerous conditions. 30% do not qualify for Medicaid. Expanding Medicaid would allow many of those to now receive services while they're on the wait list. It would also help our medically needy or spend-down population, as well as our individuals who have mental disabilities, other physical ailments, cancer, chronic conditions who don't meet that Social Security threshold. They could now qualify for Medicaid because that categorical requirement is now removed. Another factor about Medicaid expansion, in addition to the 90% FMAP, which you heard, is there is the enhancement of about $500 million that would come into Kansas. That is a 5% sweetener for our existing population. That would allow us to pay for Medicaid expansion for about 8 years with no cost to the state. One of the other last things I would say is there's the work requirement provision in the bill. I would submit that we modeled that after the SNAP, which is already the supplemental nutrition program that we have here in Kansas, with the same work requirements as well as exemptions, which is already approved by the federal government, in hopes of giving us the best opportunity to have that approved. And with that, I'll be happy to stand for questions at the end at the appropriate time. Thank you.
All right, we're going to take all of our proponents at once. Thank you very much. Next, I have Representative Donnie Lambeth, North Carolina Legislature, virtual. Are you with us?
We're here.
All right, go ahead. 4
And I
minutes,
have-
or 3 minutes is what you have.
I have Senator Bergen here with me, and he will share some of the talking points. I'm
Okay.
going to touch on just a couple points in my limited amount of time. North Carolina's been on this journey for 10 years. Several major issues during that discussion included, can a work requirement be included? If not, is there an alternative? How will our state share of expansion be funded? How can we implement expansion without fixing our traditional Medicaid, which is in need of major repair? And what are the political consequences? In 2021, North Carolina implemented a major overhaul of our traditional Medicaid, and it's working very well. In 21-22, the leadership appointed a bipartisan task force to study Medicaid expansion. And then in 23, we actually filed the bill that was passed and was signed into law by the governor in March of 23. The key aspects of that bill included a focus around wellness, which is very important, a jobs training program that provides incentives to participants who would like to return to school and better their education in order to get a better job, and funded the 10% of the state share by an assessment on providers and the managed care plans. No state funds were used to pay for expansion, and I underline that. In addition, another key factor was the bonus money from the feds as a sign-on for North Carolina, which we've been able to use in reforming several aspects of healthcare. And approximately 80% of the individuals who are expected to sign up are actually working. In North Carolina, we went live on December 1. It's gone very well. We're close to 400,000 citizens enrolled. We expect 600,000 in the final count, which is approximately 60% of our uninsured population estimates in North Carolina. We're utilizing the $1.6 billion signing bonus to reform our mental health system in a major way and to focus on workforce development, which is one of our major challenges. I'm going to turn over to Senator Bergen.
You've got 30 seconds.
Okay.
Well, I just want to say, we took $835 million of the bonus money and dedicated it toward mental health. And on the expansion population, we've already seen 500,000 prescriptions. Most of those are for asthma and asthma meds. And also the biggest thing we've seen is people that never had any care are now getting it. People have not been to the doctors for 10 years are actually getting services now. But we'll be happy to answer any questions when you get through.
All right, thank you very much. I appreciate that. Next, I have Erica Christie, Assistant Director, Three Rivers Center for Independent Living. Welcome to committee.
Good afternoon, and Madam Chair, and then good afternoon to also Representative Epley, who represents a portion of our service area, so thank you very much. I'm Erica Christie. I work for a Center for Independent Living. We work with people, all disabilities, all ages, all incomes. Everybody's welcome, and I need your help filling the gap. In the disability community, we meet people in all stages of their disability, many of whom are working part-time and desire meaningful employment, which means more hours and benefits. But they're usually dealing with some type of limitation. They don't often earn enough for health care, but they make too much to qualify for Medicaid. I can't quit my job, I can't go to the doctor, and I can't get Medicaid. That's that gap triangle that we find ourselves in too often when we're working with our consumers. And many people we work with do not have a disability determination, but do have an underlying health condition preventing them from full-time employment. It can take years to qualify for disability, and also treatable conditions that may be temporary or also don't qualify you for Social Security disability. So I have two goals today, and the first is a healthier direct service workforce, which I allude to or I describe in my written testimony. People with disabilities gravitate to this type of work because the shift work can be flexible and can be tailored to good days and bad days, things like that. And they're also passionate about working with other people with disabilities. The second goal is to get our consumers with a goal of full-time employment, to get them employed in meaningful, gainful employment that includes benefits such as health care. And I need to get them healthy as we work through that process. Thank you very much.
All right, thank you. Next, I have Dr. Doug, is it Gruenbacher, and CEO of Sunflower Foundation? Did I butcher the name?
I'm the Kansas Academy of Family Physicians. Is that correct, or do you need the Sunflower?
Oh, nope, I read it wrong. I read your academy, yes, I'm sorry.
Okay, just making sure. Okay.
Hey.
Thank you, Chairman Landwehr, and members of the committee. I appreciate you having the opportunity for us to, or for myself, to submit testimony in support of HB 2556. I'm representing the Kansas Academy of Family Physicians. My partners and I provide full scope primary care in Quinter, mile marker 107 on the west side of the state. Gove County Medical Center is the name of our hospital, and I've worked there for 21 years. And for 21 years, I've seen patients who have delayed their care due to their inability to pay, have received their primary care in the emergency room due to their inability to pay, have gone bankrupt because of their issues with payment, stopped medication or care due to underinsurance with high deductibles, and have worked multiple part-time jobs, all of which trying to make ends meet, but can't, and so they're trying to get on health insurance, but they just can't afford it. 2 years ago, I had a patient who I saw in the clinic. I was really having some symptoms. I was concerned about colon cancer, and I really needed them to get a colonoscopy. But because of payment issues and the fact that he worked a minimum wage job, he had no insurance. He couldn't afford it. Multiple months went by, and I was trying to work on that, but unfortunately, or fortunately, we did get him in to get that colonoscopy, and I took off a precancerous polyp. But I am sure that within a few more months, it would have turned into cancer. But he was lucky. If he would have had cancer, he probably would have declared bankruptcy, and due to the treatment he would have required. But this isn't just about the working class adults. Also, Medicaid expansion would help us cover some of the kids out there. And I've seen kids, for instance, a couple months ago, who had abdominal pain. I was worried about appendicitis. Tried to get them in to get testing and imaging, but would not be able to get that done. And because of that, I was really worried about him. Fortunately, that person did not have appendicitis and recovered on his own, but he was lucky. Again, this is not always the case. And again, like I said earlier, the emergency room has become the primary care location for many of our most vulnerable patients. Laws require emergency care to be given regardless of pay. And who pays for that care? You and I. And when that emergent heart attack turns into a chronic medical condition requiring multiple medications and doctor visits, who pays for that care? Most of the time, the uninsured patients will stop their medicines or treatments due to cost concerns. The inability to afford medications and treatments creates more costs for society. We have a choice. We can pay for prevention, or we can pay for preventive care. I'm just saddened by all these episodes, but furthermore, in our local hospital, we're at risk for closing. And if the hospital is closed and physicians leave the community, what will our farmers and workers do if there's no hospital? What will they do if an employee is injured in the oil fields? Where do our young families deliver their babies if the rural hospitals are closed? Expanding Medicaid isn't about giving free services to the unemployed, It's about providing health care that will extend the life of patients currently in the workforce but caught in the coverage gap. It's about supporting our uncompensated care. This isn't a political or ideological position. It's a common sense decision. We urge you to expand Medicaid for our patients and our communities. And as physicians, we cannot continue to deny our friends and neighbors
Time's
access
up.
to quality, affordable care. Thank you.
All right, thank you very much, Doctor. Billy Hall, President and CEO of Sunflower Foundation. Welcome to committee.
Good afternoon, Chair Landwehr. It's been a long time since I've been in front of you, many, many years ago.
Yes, it has
Great to
been.
be here, and my regards to all of the committee members. I'm here bringing a new voice to this important issue of Medicaid expansion, and that is the voice of small businesses. As a Kansan growing up, small businesses are the heart and soul of our communities. Doesn't matter whether you're in a small community or a large community. Many of you probably know or are part of a small business. They do not always have the ability to provide health insurance. In fact, very likely they do not. So we wanted to know, Sunflower Foundation was interested in wanting to hear from them about the opportunity for Medicaid expansion as it deals with the workforce. So with that, we approached Public Opinion Strategies and Neil Newhouse. Some of you may know this polling company. He is a very credible pollster with 40 years of experience in the field. And we went with him and asked him if he could help design a poll so we could find out, what do small businesses think about Medicaid expansion? We have never, ever asked that question. We had no idea what it would happen, what they would say. So as you'll see in the testimony and the infographic that is included in there, the most significant finding of the poll was that 83% of small business owners favored expanding Medicaid. 83%. That was before hearing anything, just the question of Medicaid expansion. While the sample size may be small, there were 107 interviews. We asked the pollster what that would mean, and given the overwhelming support for the Medicaid expansion among business owners, the margin of error on that would be 73% at its lowest and 93% potentially at the high. So we felt very comfortable with that. While the focus was on small business leaders, the poll also surveyed over 1,000 Kansas voters to better understand their views on expansion. 68% of all Kansas voters, and after they understood more about the benefits of Medicaid expansion, it went to 78% support Medicaid expansion. Since releasing the poll, I have had conversations with small businesses all over the entire state. 2 of the small businesses are in this testimony. One's agriculture and one is business, oil and gas. I wanted to know what they thought about Medicaid expansion, and I was surprised because they understand, especially with agriculture, you do not and are not able sometimes to provide that kind of insurance to that workforce. That workforce is important to the economy. So we are here to say that Medicaid expansion is more than health care. It is an economic essential. It's essential to our economy. Excuse me. Thank you very much.
Thank you, appreciate that. Next, I have Benjamin Anderson, President and CEO of Hutchinson Regional Healthcare System. Welcome to committee.
Thank you, Madam Chair. Thank you, committee. It's a privilege. I'm here with Hutchinson Regional Healthcare System. We affectionately call it Hutch Regional. I'm a Republican, been a Republican all my life, born and raised a conservative. Our family values included a genuine commitment to human life and dignity. I was raised to believe that every person was created by God with equal inherent value. No one person is better than another. Faith, family, education, and community were the foundation of our belief system. Although we experienced poverty at times, I learned from my folks that good work is good for the human soul, and anything that disincentivizes work is bad for the individual and society. I did not support the Affordable Care Act or Medicaid expansion when it first emerged. There are 3 reasons why I'm here now with in support of this bill. The first stems from my experience as a hospital CEO in 2 Kansas towns from 2009 to 2013. I was at Ashland Health Center, and during that time, our small community made a local investment in healthcare through a hospital replacement funded by property taxes, and that was that little town remains alive and well today. The second is from 2013 and 2019. I was CEO of Kearney County Hospital, where our primary care patient base grew by 60%. We recruited mission-minded doctors to serve Western Kansas through generous paid time off packages that allowed them to serve a few weeks overseas with focus on service locally. Some of those same physicians helped our hospital significantly improve birth outcomes for women in a 20-county region. During these 11 years, I saw the grim reality of uncompensated emergency care for uninsured Kansans drive up the cost of health care for insured Kansans. That trend was leading to increases in write-offs associated with high-deductible plans. Each year, our hospital had to scrape together the money to stay open, and around that time, we started seeing the financially distressed rural Kansas hospitals close their doors. This dynamic still exists today. The second is connected to my experience working as vice president for the Colorado Hospital Association. My role at the association was to directly support the 45 hospitals outside the Front Range, the rural folks, the little guys. I had intimate access to their financial and operational realities, and I assisted in their strategic plans, board development. I served as an informal coach to many of those CEOs. Colorado is a Medicaid expansion state, and to my knowledge, and unlike Kansas, it has never lost a rural hospital. I saw a difference between a state that did not expand Medicaid, Kansas, and one that did, Colorado. Bringing home federal dollars allowed them the margin to focus on stewardship, governance, community health, while families focused on growing their children and going to work. Uninsured patients were not among the key issues we faced in Colorado, and in a financially struggling hospital was a rare exception when compared to Kansas. The third is our current reality in Reno County. We experienced a massive hit this last couple of years, and even in 2023, a year ago, had to essentially eliminate 80 jobs. Our ED, which averages over 65 patients per day, has become a front door for the hospital, as many of those patients do not have a way to access preventive care. Medicaid expansion would significantly improve our reality. As leaders, we often debate whether access is a right or privilege. The reality is that health is a public asset and disease doesn't discriminate. In a rural community, our kids learn together. The uninsured bring sickness to the insured. There's a public narrative that Medicaid expansion hurts hospitals. That argument is arguing that expanding Medicaid pushes people from private health insurance to Medicaid, assuming that inpatient Medicaid rates are lower than private insurance rates. Hospitals would theoretically suffer. This argument is flawed in the context of rural health care because we have rural health clinics that receive increased payments from Medicaid for preventive payments. That's number one. Also, 340B through disproportionate share gives us funding. The second is that if the federal government reduces its contribution to states' Medicaid expansion, the program would be unaffordable. We're already paying for this care. As a fiscal conservative, I prefer to minimize tax burdens on our society. I believe that taxes we do pay, however, should come home.
Time is up. I'm sorry.
Thank you.
All right, next I have Tim DeWeese, Director of Johnson County Mental Health Center. Welcome, Tim.
Good afternoon. My name's Tim DeWeese, and thank you, Madam Chair, Committee, for allowing me to be here today. I provided you written testimony, so I'm not going to spend a whole lot of time specifically on that. But I just want to take this opportunity to share with you what I've seen happen over the course of the last couple of years, in particular with the leadership from this committee. I've seen it make recommendations for mental health services. I've seen it move forward significant legislation regarding mental health services, most notably the Certified Community Behavioral Health legislation that's revolutionized the community mental health center safety net. And based upon that, I am confident that everyone in this room and the room next door wants every Kansan to meet their full potential, their highest level of independence and self-sufficiency. The foundation of all three of those things happening is accessibility to health care, both physical health care and mental health care. To date, I have not heard a good argument against Medicaid expansion. The facts as I see them are expansion in Kansas will be an economic driver. It's a financially responsible course of action. It's a pro-health proposition, and most importantly, it's a pro-Kansan piece of legislation. Thank you very much.
Thank you, Tim. Next, I have Jeff Easter, Sheriff, Sedgwick County. Welcome to committee, Jeff.
Good afternoon, Chairwoman Landwehr and the rest of the committee. Appreciate the opportunity for us to speak today. I'm representing the Kansas Sheriff's Association. My name is Jeff Easter. Keeping this brief, we want to support the piece of legislation that's in this particular bill that expands Medicaid within the jails. The reason for that is that we have a lot of sick people that come into the jail. We have to, by law, by human standards, we have to provide very good care to these inmates, most of which have not had care in years. That is becoming extremely expensive. Currently, right now, if an inmate is admitted to the hospital more than 24 hours, and this legislation body about 15 years ago passed out that we would get the Medicaid rate. That is a huge boon for our local taxpayers. And I'll point that out. We had a prisoner that was charged with the crime of murder, was not going to get out of the jail, had multitude of issues, and the bill at the end of the day was over $1 million. Because of that Medicaid rate that we receive, it was over $200,000. If Medicaid expansion was to be given to our local sheriffs, that bill could be a lot less and a lot less burden on our taxpayers or up to $0 that taxpayers would have paid locally. I use that analogy or that example because you throw that out into the smaller counties, they'd go bankrupt. They have no way to afford that. When I started as sheriff 12 years ago, our medical budget was $4 million. It is now $9 million, and we go over it every year. We simply ask that there is some relief to our local taxpayers on this particular subject so that those monies can be spent in other ways within our counties. So thank you very much.
Thank you very much, Jeff. Okay, that is, where did my list go here? That concludes the proponents that we had on our list. Committee, there is written-only testimony that will be provided because of the large quantity. It's not before you today, nor is it online at this time, but it will be. We'll open it up to questions at this time. For right now, I'm going to allow 15 minutes of question. The goal would be is if we get through everyone that we have, opponents and our neutral, and give them time for questions, then we can come back and it open up to everybody to expand our questions, because I want to make sure we can get some answers. Representative McDonald.
Thank you, Madam Chair. My question's for Dr. Gruenbacher. Sorry, I butchered that. Your testimony in support of Medicaid expansion in regards to the impact it would have on children was really compelling to me. Critics of Medicaid expansion often repeat the tired talking points about adults who would benefit being able-bodied and just need to get a job, which is frankly inaccurate and insulting. Can you talk to me a little more about the parents in your practice who are the working poor? Thank you.
Yeah, that's probably a big problem with us that we have is those folks who try to get insurance for their family, but they can't afford it for themselves because they can't. And then when they can't get it themselves, they're less likely to get it for their kids. You know, to be truthful and fully transparent, a lot of kids can get insurance, but if the parents don't have that ability to get insurance, they're going to be a lot less likely to get it for their kids.
Okay, just go ahead and just stay up there. Committee, are there any other questions for the doctor so we don't have people bouncing up and down? All right, thank you. Just wanted to make sure. Next, I have Representative Blex. Who are you looking for?
That Hutchison guy, I can't remember his name, I apologize.
Are you yanking his chain a little bit, Representative?
No. Reno County's all right. A question for you. You mentioned hospital closures and issues, and as I understand it, Medicaid expansion pays about 78% of what a private insurance would go. So, and you made the situation that hospitals are on the risk of closing.
Yeah.
If we expanded Medicaid, which would automatically kick those people off of private insurance, which would be reduction in payment, how do you accommodate for that? And I understand fully that you have to treat everybody and those people that don't have anything, that you want to get anything. But if you had a large patient group of a reimbursement of 78 or 65%, could the hospital survive?
Absolutely. Matt, I'll comment directly on that. First of all, you have to look at the whole ecosystem of healthcare delivery system. So the rural health clinic gets very favorable rates for Medicaid for preventive care. And so we look at that as an offset, number one. But number two, specifically for inpatient care, which is what you're talking about, we have opportunities through a federal drug program called 340B, where if we have a disproportionate share of our inpatient bed days are Medicaid, we can qualify, in our case, for over $1 million a month in additional funding through 340B. So we have to look at the whole ecosystem. But overall, it's a net lift. So at the individual level, you might look and say, well, this percentage rate is this and that is that. But when you look at the whole ecosystem, it's a net gain for sure.
Thank you for that. Thank you, Madam Chair.
And I think Representative Blex, when you talk about that 78%, that's rather high, and we'll actually have some better numbers on that for you here a little bit later. Next I have Representative is it? Okay, who has one for him while he's up? Okay.
Thank you, Madam Chair. Appreciate it. I have a question for you on, at the hospital, do you guys offer primary care services?
We do.
Okay, can you give us an example for the committee here of what Medicaid reimbursement rate for a primary care visit looks like cost-wise?
So I'm new back to Kansas. I spent 4 years in Colorado, so I'll reference my time, 11 years in Kansas prior to that. We knew that it was around $45 we could get for one if we didn't have a rural health clinic status, but if we have a provider-based rural health clinic, it could be $200-300 per visit in a rural health clinic, which is enormously helpful within the rural health context, and we use that to improve access to care across our counties.
I have a follow-up question on that for rates as well.
One more just so we can get through our other questions, please.
Okay. My other question would be what is the reimbursement rate you receive through a traditional insurance like a Blue Cross, United, Cigna, Aetna also? And then if you have somebody walks in and wants to pay cash, what's your discounted rate for that?
So the discounted rate, it depends on income level, right? So it's a sliding scale, and so there's not one specific answer to that. But if they walk in and their income level is one thing, it'll drop. The fee they pay drops per income. But if they have if it's United or one of the Aetnas, one of the privately insured plans, it's going to depend on each individual plan and what they pay. Significantly less than what Medicaid would pay in a rural health clinic. Medicaid was our best payer in a rural health clinic.
That really doesn't answer the question, but thank you anyway. That's not 100% true, so thanks.
Representative Vaughn.
Thank you, Madam Chair. This is also for you, Mr. Anderson, if you don't mind.
Happy to fill the role of the Hutch guy.
Yes, go ahead and stay up there till we excuse you, just because we're trying to pick the one so you don't bounce back and forth.
Yes,
so.
ma'am.
Thank you.
Thank you. Thank you, Mr. Anderson. Since you've worked in other states and since we are one of the very last states to expand Medicaid, I'm wondering, have you seen healthcare providers in Kansas move to other states that have expanded Medicaid?
Yes, I recruited some when I was in Colorado. I pulled some out of Kansas and recruited them to Colorado, and it's a very different environment. I was surprised, and part of the reason I came here, I think I left the state. I probably wouldn't have come up here, but I'd seen what I saw in Colorado, and I saw them not have to worry about how a patient pays for care. And the doctors we recruited out to West Kansas were missionaries. They got into this, they meant what they said in their med school interviews. They really wanted to heal the sick, care for the poor. And they were able to come to a state where they didn't have to think about that anymore. And they could just care for people. And however it works out, however it works out. And the next generation of physicians wants to work in a situation where they don't have to think about how people pay for care. So yes, we recruited physicians out of Kansas into Colorado when we was there, and I found that to be decidedly less challenging.
I agree. It'd be really nice to keep those providers here and to have that access to care for people in Kansas. Thank you.
Representative Clifford.
Thank you, Madam Chair. Ben, good to see you. And as you know, I represent Kearney County. Your written testimony sort of connects expansion to reduction in taxes like property taxes. Would you expand on that? Thank you.
Sure. I'll share that in the 2 hospitals that I ran before I got to Hutch Regional, we lowered property taxes. Again, I'm a Republican. I don't like paying taxes. And so we saw an opportunity to reduce the burden on local folks through the use of federal programs. And the first case was Ashland. We used the swing bed program and figured out how to care for, in a long-term setting, care for elderly folks. Well, that changed the amount of federal reimbursement we were able to receive, so we therefore lowered property taxes. In the second case, it was the use of 340B, the prescription drug bill that we mentioned earlier. As we built that out, we were delivering moms, caring for babies. Our disproportionate share of our Medicaid days went up, and we were able to pull down those dollars through that federal program and therefore significantly reduce. In fact, we went from $1.5 million in local property taxes supporting our operation down to $500,000. We lowered that risk. The expansion of Medicaid would take dollars that we're already paying out to the feds that are going to California, Colorado, New York, Florida, and it would pull them back in here so that we would not tax our local folks, essentially double taxing them property taxes on top of the federal taxes they're already paying and not getting back.
Thank you, Madam Chair.
Representative Reese.
Thank you so much for your testimony. The question I have, and you've touched upon it a little bit more, or a little bit already, is how can Medicaid expansion lead to healthier moms and babies?
Well, in West Kansas, we would use the words in Spanish, las madres tienen las llaves del reino, which means the mamas hold the keys to the kingdom. If we take good care of mothers, they take good care of everyone else. There's plenty of good public health research around that. So we focused on, by providing access to maternal care, very good quality maternal care. Moms bring everyone else. There's only one human being in the entire earth that can convince me to get a colonoscopy, and her name's Kayla. She's my wife. And moms can pull their families into a healthcare delivery system in a preventive way. And when we're providing access to them and to their children, they bring the whole ecosystem together. Any other questions?
Are you for him? All right, do we have any other questions for, all right, thank you very much, appreciate it.
It's an honor to be with you all, thank you.
Thank you. Okay, next I have Representative Haswood, and who are you looking for?
Thank you, Madam Chair. Senator Jim Bergen and Representative Donnie Lambeth.
Are you still online with us? All right, we have a question from Representative Haswood. Go ahead.
Thank you, legislators, for being with us today. If I heard your testimony correctly, or I've read, but I've heard that you both opposed Medicaid expansion in the past. Can you share why you changed your position on that?
Yes, ma'am, be happy to, and thank you. Going backwards, if you look at it, we did not have managed care in place in this state. So we were having wide swings in the amount of Medicaid. I mean, it would be as much as $500,000 that we would, $500 million that we would be out. And so when we put in managed care with our PHPs, we got that under control. We got it balanced and got it to where we could really start looking at it. But all of us have been against it for years and years because we thought, like a lot of the folks that have spoken at an earlier meeting, and I'm sure will probably speak, they talk about all of the different expenses and how it's going to run up costs. I'm in the insurance business. I've been for 34 years. And what we've got to remember is people that are on affordable health care, they're already on a government program. If they're subsidized and receiving a subsidy, that is government money. Also, most of them have a high deductible. I had people that I would write insurance for, and then they would get off of it the next year because they would have a claim. They'd go to the hospital, and it would end up with an $8,000, $10,000 deductible. So even if you're on a zero-based plan and you have a $1,550 deductible and copays on there on a person, and even in the expanded community, that's 7.5% of their income. So, you know, it's really, we felt like we had a fiduciary responsibility to take the money. To the state of North Carolina, it made about a $7.5 billion change in health care. And then working with the hospitals through the HAS money, the Hospital Access Stabilization Program, we saw what it was going to do for them. We don't think we'll have any of our hospitals closed in the future because of what we've been able to do. So it's made a big difference. And as a Republican, I don't think we could have afforded to turn down the money plus the bonus money. As I said, about $1.6 billion bonus money, and we committed $835 million of that to mental health. And I've traveled all over the country talking to people about mental health, and every state is dealing with major mental health issues right now.
And I would add that that I was also opposed, but I felt like we needed to create a North Carolina plan and solution. And so I was opposed to the early plans because it was take it or leave it. And we did that. We have a focus around wellness. The state does not put money in. In fact, we will actually net new money because it will cover some of our costs for the state operated hospitals. And we felt like with the job training program, because we really wanted a work requirement, and looking at the court cases, we felt like we couldn't go down that path. So we went with a jobs training program where Commerce and Labor are putting together a program that will allow individuals who are on the expansion to take advantage of that if they're interested. So there's incentives built in to do that. And I felt like that the North Carolina plan was actually better than, and we did, take the best parts of other states that we had heard from to create our own plan. So it's a North Carolina option that I'm in favor of, not the traditional plan that came out way back in 2012.
Thank you.
Representative Orpeza.
Thank you, Madam Chair, and thank you, Senator and Representative, for being here with us today. It's greatly appreciated. My questions revolve around the economic impacts and economic development that you've seen since you've expanded Medicaid. Can you speak to those, please?
The best place to do business for the last 2 years. We have people that are flocking to North Carolina. We've got one of the lowest tax rates in the country. We just lowered our tax rate again. I get calls almost every week from people wanting to come to North Carolina to do business, especially since we've expanded Medicaid. I got a call last week from some folks that are wanting to bring mental health services to North Carolina. That didn't happen in my prior 5 years in the Senate. So I think it's been a big difference, and I think people are seeing that we're committed to health care.
Thank you.
Senator, did I hear you just say that basically Obamacare is not the health care cost savings that everybody was led to believe when it was passed because of the high deductibles?
As an agent that opposed it when it came about, and I told our local congressman who was a big proponent of the affordable health care, that anytime you set up where there is a gap, you're picking winners and losers. We did the same thing when, it was the Bush administration that did it, the donut hole on the Part D, the drug part for Medicare recipients. Now that's being fixed now, but we would see people come on, flock on at first, and then when they would start getting their bills from the hospitals and see the things that weren't being paid, they would go off. I would have people that were getting 100% of their premium paid, and they would drop off the next year. So, it's just like the hospital administrator said earlier, the money's already being paid, and I'm a business guy. I don't spend money, I invest money. And I saw Medicaid expansion as a good investment in healthcare.
Well, but I don't believe that you've answered the question then, or maybe you did in a roundabout way, that Obamacare has not reduced health care costs.
I don't see that it has, no ma'am.
All right, that's what I wanted to get. Representative Reese.
Thank you, Madam Chair. My question for you is, I've heard many people say that they just don't want to allow able-bodied people to have Medicaid or access to Medicaid expansion. How, I'm sure you heard the same thing there in North Carolina. How did you answer that? And how are you able to convince those that said that to change their mind?
We did hear that, obviously, and, you know, we just felt like that the benefits far outweighed that concern, because these individuals, and we've had people stepping forward that's told us that they've not been able to go to work because they've had health issues and they could not get health, coverage and health care, and they're getting it now, and they're actually looking for a job. And when those stories have been circulated, it makes it all worthwhile, quite frankly.
And a lot of the people that are working, that are on, that are going to be on the expansion population, they're in jobs that their employers don't offer. We have been big proponents of, association health plans and things like that, so that people can pool their employees and groups like realtors and restaurant owners can pool to be able to offer plans. And until the federal government moves on that, this is what we see as the best way to approach this.
Thank you.
And I don't recall if this is something that you gentlemen touched on, or perhaps it was from the Hutchinson Hospital, but the discussion on low-income pregnant women already qualify for Medicaid, and their child will qualify as well, and about 50% of babies are born through Medicaid. Would you agree with that?
Yes, ma'am. 52% of all the babies born in North Carolina were paid for by Medicaid. Before we expanded Medicaid in the prior budget, we actually extended coverage for moms up to 12 months. That was kind of the first step, and we saw the success in that. We don't like our results on infant mortality. We're working on that, especially in the Black community. It's about 2.5 times what it is in the white community. And a lot of this money and a lot of the expansion we're looking at is how to drive those down.
All right, thank you very much. All right, committee, we're going to move on to our opponents. And like I said, if we have the amount of time, then we can come back to proponents. And so if you think of other questions, let me know. Our first opponent would be Representative Will Carpenter. Welcome to committee, Will. I guess I should say Representative Carpenter, welcome to committee.
Good afternoon, committee members. Pleasure to be here. Many of you know that I could bury this whole committee in information about KDHE and KDADS and mental health. But what I want to talk to you today about is one of my big concerns about expanding Medicaid, which is our most vulnerable people, our ID and our DD, our frail and elderly, those folks. You know, many of you have been around this session. We've taken 500 people off of our wait list. We still have, even with that, we're going to have 4,800 people left on that wait list. We've taken 500 people off the physical disability wait list. Even with that, we're going to have about 1,900 people in there. I'm really concerned about expanding Medicaid to 150,000 more people when we don't take care of the people that we have now and that are under our care. So I just want to give you a little bit of rundown kind of numbers. Current Medicaid population, 387,000. That's Medicaid only, just CanCare Medical. Total Medicaid population is 456,817 folks. Total cost, $5.4 billion, $2.2 billion SGF. That's just for KDHE. Go to KDADS, $2.7 billion, all funds, $1 billion SGF, 28,000 people roughly we serve for that. Our nursing homes, $862 million is what we spend on them, $303 million worth of SGF. You see where I'm going with this? We need to take care of these folks. And when we get started down this Medicaid roll, I'm real concerned about how that, and I'm not going to beleaguer this, the chairman will be on to me about this, but this was a Wall Street Journal article, and it says disabled will pay for Indiana's Medicaid forecasting area. They're $1 billion short. So when you go to cut, and we're getting reimbursed at a 60-40 on our, thank you. when we're getting reimbursed 60/40 on our folks that are already on Medicaid, and we're going to cut 90/10, we're getting 90/10 on the other folks, where do you think you're going to cut? You're going to cut on the one that saves you the most money, which is a 60/40 folks. So I'm really concerned about that. Another thing I might just, I got a little bit of time here. So this is a article here from the KLRD got for me, talking about other states that expanded Medicaid. Arkansas, for instance, they expanded in 2013. The estimates were 200,000. The next year was 245,000. In 15, it was 245,000. 18, 252. 2020, 278. 8 years later, it's 312,000. The uncompensated care, which you hear a lot about, and you think that that might just completely go away, it was decreased by 58%. So it's not like uncompensated care is going to totally go away for these folks. Iowa, same thing. 2012, 21, they've got another 33,000 folks in there, 46% decrease. And also back to some of these states, so uninsured rate, 2014, 22.5%. In 15, it was lowered 1%. It's decreased 51%. So the uninsured rate has gone down. Thank you very much. I could go on, as many of you know, for several hours on this, but in the interest of time and all that, I'll just stand for questions at the appropriate time. Thank you.
Thank you very much. Next, we have Beverly Gossage, Senator from Johnson County. Welcome to committee, Senator.
Thank you, Madam Chair. Nice to be with you, committee. Because of the sake of time, I am just going to focus on my field of expertise. We are a citizen legislature. If I went around this room, most of you could tell me what your real job is. Some of your real job is a doctor, an optometrist, a farmer, et cetera. Mine is a health insurance agent, so I help people find affordable health care. That includes with Medicare and also assisting people on signing up on Medicaid. I'm going to focus on the non-group business or the non-group community. So if you have my testimony before you, if you look at the bottom of page 1, it said who would be eligible for Medicaid expansion. We've been hearing through the governor and traveling the state and others, that's 150,000 people. But then again, when you take out the folks that are already insured, and of course you remove the 46,000 children, because children are not in the Medicaid expansion population, you'll find that that number is smaller, because many of these folks, in fact, about 50% of folks nationwide already had insurance before being thrust into Medicaid expansion. So to be in the Medicaid expansion, as we heard, you would be earning between 100 or 0 to 138% of the poverty level. If you make between 100 and 138% of the poverty level, you're already eligible for an amazing plan on healthcare.gov. Did it help the middle class? It did not. It hurt them, but it helped the low-income people in this way. So if you worked at Wendy's $12 an hour, 25 hours a week, that's about $15,060. On page 2, you'll see what the plan would look like if you would go to healthcare.gov. You'll see it is a 0 premium, a 0 deductible. You'll see that your doctor's visit would cost you $5. You'll see specialists would be $10. You'll see urgent care at $30. You'll see $5 for mental health. You'll see no charge for generic drugs. Pretty amazing policy. I think we would all want that. Yes, there is an out-of-pocket of $1,550, but it would be all of these copays adding up to that amount. You could choose a $7. There's a lot of plans to pick from. You could choose the one. By the way, this is an actual screenshot of my helping someone directly from my computer from 2 days ago. So $7.68, and that would give you again, a 0 deductibles, and however you would have 0 charge to see the doctor, $5 for specialty care, no charge for mental health, et cetera. But what happened if Kansas were to expand Medicaid? Like all states that expanded Medicaid, this entire population would receive a letter in the mail that would say, congratulations, your state expanded Medicaid. You can go on to Medicaid because you're eligible, or you can keep the plan you have. If you turn the page, you'll see these clients of mine that call me because I'm licensed about half the state say, What does this mean? It says, or you could keep the plan you have, $389 and $5,750 deductible and $8,900 total out of pocket. That's not the plan I had. I'm sorry, that is the plan you had. They remove all of the subsidies. So the minute the state expands Medicaid, they've removed all the subsidies. So you do have an option. You could take this plan without any of the subsidies, or you can go on to Medicaid. Now, this fellow is under 30, so if you're 30 or under, you could get the catastrophic plan. That's $256 and a $9,400 deductible. He can't choose either one of these. It's a false choice, so of course he would go on to Medicaid. So if you look at the graphic right below that, when helping a family who had 2 children, one in Kansas, one in Missouri, going to school, I showed her that first plan for her daughter, and she said, oh, this is awesome. Can I get the same thing for my son? I said, I need age, I need income, I need zip code. His zip code was Missouri. This is what pops up when you put in a state that expanded Medicaid. And it says you qualify for Medicaid. If you want to look at plans on the exchange, they're full price. I would echo what was said by Representative Carpenter. I've chaired the IDD committee. We need to focus on these folks and try to look at a way of doing the community-based waiver. Also, we just want people to work. We don't want to make sure that we don't have any barriers to work. We don't have any barriers to our employers of hiring, because if you just make that small amount, you can get an amazing health insurance policy. Thank you for letting me be with you today, committee.
Senator, if you'll hold just a moment, I believe, are you on the floor at 2?
2:30.
2:30. I think what I'd like to do is, if you wouldn't mind, if you've got questions for the senator right now, we would take them so that we don't have
That
you
would be
miss your
great.
floor
That would let me get to Education Committee that started at 1:30.
Oh, okay.
Thank you.
Are there any questions for the senator? Okay, Representative Bueller.
Thank you, Madam Chair. Thank you, Senator. So in the research that I've done, I have found, I think, these 3 or 4 things to be true. Any state that has expanded Medicaid, the number of enrollees is grossly understated. The cost to the state is grossly understated. And there's a contraction of the workforce by 7 to 11%. Are there any states that you know of that have expanded Medicaid where those things aren't true?
Not that I'm aware of, but I'm sure there'll be other proponents or opponents that will address that. The one thing I have researched is that about 52% of the people on the Medicaid expansion population in all of the states that have expanded on average do not work at all.
Thank you. Thank you, Madam Chair.
Representative Barth.
Thank you, Madam Chair, and thank you, Senator Gossage. So when we started this today, I had looked at page 3, 27, lines 27 through 31. It talks about capping payments at 2% of the federal poverty level. And then, that estimate, I looked at the cost of that, which is like over $600. And you just told us about a plan on healthcare.gov that they could qualify already for, that maybe they could pay if they go see the doctor, $5 per doctor's visit, and that's it?
Correct. Some are zero, right. One thing I would point out at the top of the next to last page from the Kaiser Family Foundation says, 0 premium plans with enhanced subsidies are available for many low-income people, particularly in states that did not expand Medicaid.
Thank you. That's amazing. Thanks.
Committee, are there further questions for the senator? All right, seeing none, I appreciate you being here today, and I guess I'll probably see you later on this afternoon for a conference committee.
Absolutely. Thank you.
Thank you. All right, committee will continue with our opponents, and next I have Sam Adolphson, is that correct? Visiting Fellow Opportunity Solutions Project. I'll get it out there.
Madam Chair, that was correct. Thank you. Thank you, Madam Chair, committee members. My name is Sam Adolphson. I'm a visiting fellow at the Opportunity Solutions Project. I'm also the former Chief Operating Officer at the Maine Department of Health and Human Services, where I helped run the state's Medicaid program for a couple years. OSP strongly opposes HB 2556, which is Medicaid expansion. I just want to be clear about that. This proposal in front of you is 100% the Medicaid expansion that was first offered by the Obama administration about a decade ago, and that Kansas has rejected time and again. There's nothing new or innovative or certainly conservative about this proposal. There are some buzzwords that were included and have been marketed with it. Those are not genuine attempts at compromise or cost control. It is Medicaid expansion, and North Carolina's is as well, purely Medicaid expansion. I think an important thing to understand about this as well is that this bill may be the most poorly named bill in Kansas history. It only gets worse after the title. Naming it the Cutting Healthcare Costs for All Kansas Act is just factually wrong. But it's hard to blame the authors of that title when you hear what some of the alternatives might be. For example, the Cutting People Off Their Private Healthcare Plans Act wouldn't be that popular, but it would be accurate because, as the senator mentioned, there are about 36,000 people who would lose access to coverage they have today on the exchange, a private health care plan. The Cutting Reimbursement Rates to Rural Hospitals Act would be correct as well, but obviously not as compelling. Medicaid, as we heard, pays hospitals significantly less for Medicaid than private insurers. And FQHCs, by the way, they get that enhanced Medicaid rate in exchange for covering the uninsured. That's why they get a bump in their Medicaid rate in those FQHCs. I definitely understand why the authors chose not to call this the Following Other States Failures Act, because that doesn't sound very good, but it is accurate. Section 4 of the governor's proposal gives an option for the administration to run a so-called private option. That's been tried in 3 states, Iowa, New Hampshire, and Arkansas. Iowa and New Hampshire gave it up because all the insurers left, and it cost double what they thought it would. And in Arkansas, the private option plan cost twice what traditional Medicaid expansion cost. It's also true that in the bill, there's no requirement that the governor run that plan anyway. It's an option. It says may. So the option is, do you kick 36,000 folks off their private plan, or do you run a plan that 2 other states have left and is twice as expensive? Not much of a choice. The Expanding Welfare to Only Able-Bodied Adults Act probably wouldn't be very popular with your constituents, but that's exactly what the bill would do. These are non-disabled adults. They're not kids. They're not elderly or disabled individuals. They're able-bodied adults, many without kids in the household. Or what about the Cutting Into Other Budget Priorities Act? Medicaid in Kansas has gone from 7% of your budget to 23% in just 2 decades. Already, without this expansion, you're seeing Medicaid gobble up all the rest of your spending. And maybe, and lastly, the most disturbing title that was not chosen is the Washington, D.C. is in charge now Act. And the provisions in Section 3 and 4 that have been mentioned, the work provisions and some of the other premiums and cost controls is totally dependent on federal government approval. And it's approval you're not going to get. And worse yet, there is a non-severability clause in this bill, meaning if you don't get that work requirement, if you don't get cost sharing, Medicaid expansion goes forward just like the one they have in California and New York. So with that, I'm happy to stand for questions at the appropriate time. Thank you, committee.
All right, thank you very much. Next, I have Michael Cannon, Director of Health Policy Studies, Cato Institute. Welcome to committee. It's been a while, Michael.
Thank you, Madam Chair, for having me back in putting my testimony. And I want to make a general comment that the Cato Institute does not take positions on legislation. I'll just be talking about the concept of Medicaid expansion broadly. I first testified before the Kansas Legislature on Medicaid expansion back in 2013. I testified at the time that Medicaid is rife with waste and fraud. Some people have been promoting a type of Medicaid fraud in this hearing. We could discuss that later. It increases the cost of private health insurance, crowds out private health insurance and long-term care insurance, discourages enrollees from climbing the economic ladder, I pointed out there's scant reliable evidence that Medicaid improves health outcomes and zero evidence it does so in a cost-effective way. I noted that if history is any guide, the cost of the Medicaid expansion would exceed projections, and I encourage the legislature and Medicaid expansion advocates to do the research to find out whether expanding Medicaid would improve health outcomes. I also advocated that the Kansas legislature enact reforms that would improve access for the very people we care about in this Medicaid expansion population without costing taxpayers a dime by liberalizing clinician licensing regulations, giving health insurance purchasers more choice, reforming medical malpractice liability, and so forth. Now, since 2013, the cost of Medicaid expansion has exceeded projections in states that have expanded the program. Kansas has not enacted the licensing and private health insurance and medical malpractice reforms I would have liked to have seen. They've taken small steps in that direction. Kansas has wisely not expanded the Medicaid program, but Kansas has also not done the research that might have told us whether and to what extent Medicaid expansion improves health. It is easy to assume that compelling taxpayers to spend more money on health care will improve health. But if that were the case, then the United States would lead all nations on all health measures because, as the OECD tells us, and my written testimony illustrates, the United States compels taxpayers to spend a larger share of national income or gross domestic product on health than any other advanced nation, by far. The most reliable study that we have available to us on the question of whether Medicaid expansion would improve the health of the targeted population, studied randomly assigned people, the most vulnerable people in that population, people below 100% of the federal poverty level, either to receive Medicaid or not to receive it. And that study found that that Medicaid delivered no improvement in physical health outcomes, including physical outcomes amenable to preventive care. So the science is telling us that we don't know what taxpayers are getting for the money that they give to fund the Medicaid program, much less what they would get from funding the Medicaid expansion. And in the 11 years since I first recommended that Kansas collect those data, do that research, the state has not done so. Advocates of Medicaid expansion have not joined me in calling for the collection of those data. Instead, they have spent the past 11 years trying to hide the cost of the expansion, playing games with provider taxes and other gimmicks that try to make this proposal seem less expensive than it actually is. If they had joined me in calling for the collection of reliable research on the effect that Medicaid has on health outcomes, they might have a stronger argument for expansion than they have today. Instead, the case for Medicaid expansion is weaker now than it was when I testified here in 2013, and I look forward to your questions.
All right, thank you very much, Michael. Next, I have Brittany Jones, Director of Policy and Engagement, Kansas Family Voice. Welcome to committee, Brittany.
Chair Landwehr, members of the committee, my name is Brittany Jones, and I'm the Director of Policy and Engagement for Kansas Family Voice. We represent thousands of Kansans who care deeply about mothers and babies, but they also care about tax dollars being used to pay for abortion. And I'm here today to highlight the grave concerns that we have that could arise if this body expands Medicaid because of a court ruling from 2019. I am not here today to argue about whether the court case was correct or right or wrong or anything in between, but simply to present the legal, factual account of the case law, as well as what has occurred in other states when they have expanded Medicaid. The Kansas Supreme Court created a right to abortion in the Kansas Constitution in the Hodes and Nauser versus Schmidt decision in 2019. This case now requires strict scrutiny, the highest level of legal review be used anytime we're dealing with a case that is deemed to abridge the right to abortion. This standard assumes that the government, the legislature, that your regulation was invalid. In the court's decision, the court cited to 5 different state court rulings that required state funding for abortion through Medicaid. Further, according to the abortion industry's own research arm, the Guttmacher Institute, 17 states cover abortions through Medicaid currently. In 9 of these states, this was a mandate from the court, not through the legislative process. Our Kansas Supreme Court relied on 5 of these states when they made their ruling. By relying on these cases in its decision, the court has set a groundwork for a case that will eventually deny your ability to restrict state funding for abortion. Since the 2019 HODI's ruling, we have already seen several of our pro-life laws struck down or enjoined. Given the opportunity, the court is likely to apply HODI's in a way to force this state body to pay for abortions through Medicaid. This body will no longer be able to rely on statutory provisions that protect state taxpayer dollars from paying for abortions. We have seen this in other states that have expanded Medicaid as well. Based on reporting from the abortion industry itself, we know that last year we were on target to have around 20,000 abortions in Kansas. Several other states that have expanded Medicaid wound up paying for more than 50% of the abortions through Medicaid because of expansion. I don't think Kansans want to be paying for the majority of 20,000 abortions in our state. I would posit this is something they would be very much opposed to. I ask you to oppose this legislation when the time comes, and I stand open for questions at the appropriate time. Thank you.
Thank you, Brittany. Next, I have Dean Clancy, Senior Health Policy Fellow, Americans for Prosperity. Welcome to committee.
Thank you, Madam Chair and distinguished members of the committee. It's a real honor and a privilege. I'm Dean Clancy, Senior Health Policy Fellow with Americans for Prosperity. I'm representing AFP Kansas today. We do oppose Medicaid expansion and have done so consistently over the years. I would like to praise you and congratulate you on not expanding Medicaid over the years. You've been deliberate and thoughtful and, in my opinion, wiser than other states because you have looked at this carefully and decided to take a pass. We hope you'll continue to do that. By the way, I also want to praise you for some very good health policies that reflect what we call a personal option approach to health reform. Medicaid needs to be reformed. American health care needs to be reformed. Medicaid expansion is the wrong way to go about it, but there's some very good ways, and you've done some here in Kansas. You have a great bill on, or excuse me, law on Farm Bureau-style health plans, very affordable. Only 5 other states have done that, so thank you, Kansas, for leading the way. You have a good safe harbor law on direct primary care arrangements, an extremely affordable way to access primary care without the insurance company middleman, without extra fees and hidden charges. This is a growing movement. Kansas has led the way. You have no certificate of need laws, those protectionist hospital schemes that so many other states have and which we work hard to repeal. You've passed by that because it's not a good policy, and we thank you for that. Medicaid expansion, the costs will turn out to be higher than even the highest official projection during the debate. That's been the experience of most other states. I worked in the White House as a budget and health care official. I helped states negotiate, or helped the feds negotiate Medicaid waivers with states. And it turns out because people come out of the woodwork and more people enroll than expected, and because there's so much crowding out of private coverage, the costs almost invariably are at least double what was projected during the legislative debate. Meanwhile, the income that would help fund the expansion is not reliable. The feds are promising 90% of the cost, but one of the top budget-cutting ideas in Washington is to lower that match rate. This is already in the official House Republican budget plan. If they get a chance to govern, even as soon as 2025, you can be sure that that 90% figure will move downward. Their proposal is to move it all the way down to the regular Medicaid match rate, which in this state, I believe, is 62%, the federal match rate. And so that would mean the costs of the expansion would be significantly higher than are projected. By the way, a note about rural hospitals. They have continued to close despite all the states adopting Medicaid expansion. The evidence is very weak that Medicaid expansion actually prevents hospital closure. It may mean more revenue for some hospitals, and that may be important for them. But hospital closure, the evidence is not there to say that it prevents it. Medicaid expansion is ultimately all or nothing. A state really can't tailor it or dial it or phase it in or up or down. Work requirements won't stick. Private option actually costs you more money. basically, it's a binary, it's like a light switch. You either are on or off. So when the federal promise is broken and the 90% falls, you'll be forced to actually act on that threat in the bill that says we're going to just disenroll these people. And so you should think about that before you actually adopt it. Instead of Medicaid expansion, why not go down the road that Kansas already leads the way on, a personal option, giving patients more control and choices, letting people have generous federal subsidies for the health insurance of their choice, access to HSAs, direct primary care, removing barriers, and yes, strengthening government safety nets like Medicaid. Instead of Medicaid expansion, why not a personal option?
Thank you very much. All right, committee, that concludes our opponents, and so we'll provide 15 minutes of questions and answers. Are there questions for Representative Bryce? Who are you looking for?
Thank you, Madam Chair. I was looking for, I'm sorry, just one second.
That's all right. This is on opponents for right
Mr.
now.
Michael Cannon? Thank you, Madam Chair. Mr. Cannon, thank you for your testimony. One thing that you said really was a red flag to me, and I don't think we delved into it too much, and that was fraud. And so I was wondering what you meant by that, and can you give us some idea about extent of fraud with Medicaid? And you mentioned there was even some fraud proposed today, I believe?
Yes.
Okay, thank you.
So fraud, for decades now, the Government Accountability Office in Washington, D.C. has flagged the Medicaid program as being a program at a high risk for fraud. Only a few select federal programs get that designation, although the number seems to be growing. And the official estimates are often around 10% of Medicaid expenditures go to fraudulent activities. But fraud experts outside of the government, including Malcolm Sparrow at Harvard University, have said that actually those estimates are comfortingly low because the amount of fraud, well, first of all, fraud's hard to measure because they don't want to get caught. And so people hide their fraudulent activities. The amount of fraud is actually much higher. There have been estimates that it's 30 to 40% in some areas. And so whenever you see an official estimate, remember Malcolm Sparrow's words that those estimates are comfortingly low. But there are other types of fraud that unfortunately are perfectly legal. And we've been talking about them today, and there's even some embedded in this bill. The federal government, when it created the Medicaid expansion, it told states that if we will pay for 90% of the cost of this program, and the state will pay for 10% of this cost. And in my remarks earlier, I mentioned that over the last 11 years, what proponents of Medicaid expansion in Kansas have been doing is not trying to find evidence about whether it would help people, but trying to hide the cost so that they could gain access to these subsidies. One of the ways they've tried to hide the cost is by using what we call a provider tax, which is really just a shell game. And our friends from North Carolina were talking about how they used this shell game largely to make the federal government cover all of the cost so that the state wouldn't have to pick up any of it. The shell game that they use is instead of the state paying its 10% share of the program, it will initially put some money forward, but then tax that money back from the providers. After that money has already pulled down some federal revenue, then the state takes its original investment and spends it on roads or whatever else. So that is a state gaming the federal Medicaid rules in a way that they're not supposed to do. Unfortunately, up to a point, though, it is legal. But it is a fraud in the sense that the federal government has told states, and states have told the people, the federal government's going to pick up 90% of this, and states are going to pick up 10%. And then that's not what we end up getting at the state level. And so, it is. I find it ironic that there has been discussion about fraud, but and how that is a problem in the Medicaid program, and yet here we are actively. We're talking about proposals for the state to engage in even more types of fraud, not just against taxpayers in this state, but at taxpayers across the country, because that's where most of the spending on a Kansas Medicaid expansion would come from.
Thank you, Madam Chair. Just one quick thing. I kind of think of fraud as different from shifting of funds around, but if I could go back to the first, you said 10% is a government estimate of Medicaid fraud, and then outside groups 30 to 40% possibly in some areas. Can you give some perspective on how much money that would be for the state of Kansas in fraud?
I am not. I think the Medicaid director could give a better estimate of that.
Okay, thank you, Madam Chair.
Okay, Michael, stay there. Does anyone else have any other questions for Michael while he's up there? Representative Haswood.
Thank you, Madam Chair. Quick clarifying question. So the part where you mentioned fraud in your testimony, was it just the first page that references yourself and the Cato Institute?
And previous publications that I've put together citing the authorities that I've mentioned today and as well as many others. It's not a controversial question in that there is a lot of fraud in these programs.
Okay, I just saw that you cited yourself quite a few times. Thank you.
Seemed the
Are there any other
shortest
questions
way.
for Michael? Michael, so with your conversation on the fraud, and this is kind of something we've heard here for a while, is then more than likely we'd have to figure out how to increase our Inspector General's powers that we have to go after Medicaid fraud and probably staff. Would that be an accurate statement?
It would, but unfortunately, the way the federal government sets up the Medicaid program, both the old Medicaid program and the Medicaid expansion, there's no incentive for the state to do so, or the incentive for the state to do so is much smaller than it should be. If the state invests money in policing fraud in a Medicaid expansion, but the state is only putting forward 10% of the funding, then any fraudulent money that it recovers, it only gets to keep 10% of that, and 90% goes back to the federal government. So the incentive for the state to police fraud is very low. That's why there is so much fraud in these programs, because accountability is so diffuse.
Okay. And I don't know, Michael, if you can answer this or if someone else can. Have we seen an increase in physicians taking Medicaid because of expansion?
I think that I'm not sure about the numbers as a share of physicians who agree to take Medicaid patients. I can confidently say that the amount of physician billing from the Medicaid program does rise. But there's nothing inherent to the Medicaid expansion that will encourage more physicians to accept Medicaid patients. You would have to change payment rates for that.
All right, that's what I thought. All right. Thank you very much,
Thank
Michael.
you.
Anyone else have questions for any of our opponents? Representative Barth.
Thank you, Madam Chair. This would be for Sam.
State your name for us again, please.
Yes, ma'am. Sam Adolphson.
All right. Thanks, Sam. I've been looking a little bit at certain things around IDD wait list. We had the gentleman on, the senators for North Carolina. Looking at the data, there's around 15,000 people who are on the wait list with the IDD wait list, and that the average wait is like 9 years. Here in Kansas, sitting on the social services budget, Representative Carpenter told us a lot of concerns around it. Those are concerns of mine too. I'm wondering, I've looked online too on some research. I'm wondering if this is true, if you can help me a little bit more what's going on in Indiana too, because they've also been cutting services, I'm reading, when they expanded Medicaid to cut back on some of the medical expenses. And I'm wondering if you have any further information that you could share with us other than what I've been reading online.
Sure. Thank you, Representative, for the question. It's kind of the fundamental issue in this bill is that you're providing a new benefit. It's expansion to a new eligibility group. It's not expansion of benefits to the folks who receive them today. What I would say are the truly needy, the disabled individuals, poor families, elderly. You're not expanding anything to them with this proposal. And instead, you're expanding to an entirely new group of people. Well, we know that you all live in a world of finite resources. You have taxpayers give the state a certain amount of money, and you have to, divide it up to your different priorities. So what we see in these other states, what you're referencing in North Carolina, and they're really early on in their Medicaid expansion experience. They may have a different story to tell if they come back and talk with you in a year. But you're seeing, wait lists for folks on these IDDD waivers. You have those in Kansas, been talked about a lot. We've seen this in every other state, that there have been hundreds of thousands of people over the decade, I'll get you the exact number, that remain on those wait lists. Many have died waiting for services as state after state has expanded to able-bodied adults. In Indiana, They were one of the early kind of pioneers on expansion, especially in terms of a Republican state, and they're seeing the effects of that this year. In December, they discovered a $1 billion shortfall that was previously undisclosed in the Medicaid program. And what the Medicaid agency brought forward was a corresponding cut to in-home services for the disabled. And as was mentioned earlier by opponent testimony, the incentive is all wrong with this. You're getting more federal money to cover the able-bodied adult population than you are for the truly needy. And so what happens when you inevitably come to a budget problem, and you will, Kansas is doing a great job right now, you've managed your state resources well, you will come to a budget problem at some point, and then you'll be forced to decide, do we do something over here where we're getting 90%, or do we do something over here where we're getting only 62%? And that's exactly why Indiana is continuing down the path of cutting services to the disability community.
Thank you. That answers my question. Thanks.
Representative Reese.
Thank you for your testimony. One of the pet peeves I have about people that are opposed to Medicaid expansion continue to use the phrase able-bodied adults. And on page 3 of your testimony, you've changed the title to the bill several times in your entire testimony, and it's pretty sarcastic. So you've got Expanding Welfare to Only Able-Bodied Adults Act. What's your definition of able-bodied adults?
Sure. Representative, my definition of able-bodied adults would be the same that's used in federal law in another welfare program, in this case the food stamp program. Able-bodied adults is not a term I came up with. It's a federal legal term to describe the same population that Medicaid expansion is for, which is, another way to say it would be a non-disabled, non-elderly adult who's not a child. So it's a non-disabled, non-elderly adult of a certain age. That's, by federal law, that person in other welfare programs is called, again, in law, an able-bodied adult. So that's why we use that term.
It's disrespectful for people that fall in the gap, that are going to be the ones that are going to be able to benefit from Medicaid expansion, to always call them able-bodied adults as if it's a derogatory term. And it's very offensive to them, and they've told me that themselves. So I just wish people would get away from that. Thank you.
Just a moment. Sam, okay, we've heard that Obamacare did not reduce health care costs. And do you have any comment, because I mean, this has been quite a few years back, is Obamacare also got rid of the high-risk pools that many states had in place that, you know, dealt with the population that had difficulty because of high experiences with their insurance. Do you have any information on how that has impacted what we've done moving forward?
Yeah, Madam Chair, good question. Diving deep into healthcare policy on that, which I appreciate. Yeah, you know, Obamacare fundamentally transformed the healthcare market, right? And they removed a number of things along those lines, along the high-risk pool. Some things that Dean mentioned earlier that allow people to buy private insurance in an affordable manner. And again, I would also commend Kansas. You've done some good things along that front. But the bottom line is it's a lot more difficult to purchase private insurance. Those costs have gone up. The ACA or Obamacare did not bring those down. And it was by design. You know, when they originally passed that, just to remind the committee, when Obamacare passed, Medicaid expansion was required. And they were relying on all of the coverage gains, you know, going towards that Medicaid group, which is ultimately what has happened. But the Supreme Court ultimately said you cannot make states do this expansion, which is why we're here discussing it. But overall, yes, you're right. The fundamental structure of healthcare was completely changed. It became centered around these government-run options. And that only grows in its kind of severity and effect on private insurance when you put more people on Medicaid.
All right, and then one other thing, if this isn't for you, we can go to someone else's. How does Medicaid expansion address, handle, or impact the dual eligibles, which are Medicare and Medicaid recipients?
Thank you, Madam Chair. Good question. That won't be for that population, right? There's not going to be a change in their eligibility. What it will do is, and I have seen this firsthand in Maine, is back to Representative Barth's question. It's a matter of priorities, right? You as a state decide what level of Medicaid resource you want to use to support dual eligibles. You can take that eligibility income level up and down. You can change the allowable amount of resources folks can have and still get that benefit. And if you go down this expansion path and your budget comes under pressure, that's going to be another place where you might have to look for savings. And so in that way, I would say it has a potential big impact on dual enrollment when you're pushed into, a tough budget choice. Otherwise, it's not part of the Medicaid expansion.
Yeah, because not all dual eligibles fall under the 65 plus. We have them under 65.
Correct.
All right. You have one for Sam, Representative Orpeza.
Thank you, Madam Chair. Thank you for your testimony. So when you were referencing articles, was it the article the Representative Carpenter had mentioned earlier from the Wall Street Journal?
Yes, ma'am. The Indiana story?
Yes.
That is the same story.
That
Yes,
is the
ma'am.
same story?
Yeah.
Okay. And were you aware that was an opinion and commentary and was not based off of the Medicaid agency?
Yeah, I was referencing firsthand discussions with legislators in Indiana. It is the same issue that was brought forward in the Wall Street Journal article, but everything I said about the issue in Indiana, I have firsthand directly from the state. We work in Indiana quite a bit as well.
Okay.
Yeah.
And then, so additionally, when the HCBS waivers were cut, that was completely independent of their Medicaid expansion, correct? You're talking about two different things here?
Representative, no, I would say they're directly linked because the Medicaid program has a budget. The state has a budget if you want to go kind of further, bigger picture. And $1 billion is $1 billion. And they are spending huge sums of money on Medicaid expansion. So I don't think you can de-link the two in that it's a choice you're making about how you spend your limited resources in the Medicaid program.
And then the guardrails, I'm sorry. I should have asked. Sorry, I just started the conversation. And the guardrails around these waivers, did Indiana have specific guardrails?
Can you give me an example of what type of guardrails you're asking
Or
about?
any type of waivers like hourly rates, those types of things, care rates?
There's a lot of policy options around the waivers. Theirs probably look a little different than yours.
Okay, thank you.
Committee, and I know I've got some other individuals that have questions for Sam, but we've got one other set of testimony, which is an individual for neutral, and I want to get to them, and then we can come back to questions.
Thank you.
So when we come back to questions, Sam, we'll have Representative Vaughn, Representative Blex, and Representative Bryce for you when we get back up here. All right, committee, at this time here, I would call on Carrie Bruffett, President and CEO of Kansas Health Institute. Carrie, welcome to committee.
You're saying I don't have 20 minutes?
No.
I don't have 20 minutes, okay.
I can give you 4, if you want 4.
All right, I think we can do that. Thank you, good afternoon, Madam Chair, and members of the committee. Appreciate the opportunity to present testimony. I'm Carrie Bruffett, I'm the President and CEO of the Kansas Health Institute. We're a nonprofit, nonpartisan health services research and education organization. Many of you have been over in our space just across the street from the state capitol. We don't take positions on legislation. We're neutral, and what we are not neutral on is using data and information to help guide the policy conversation. So we want you to be able to use this information to guide your overall conversation. You have heard some of the numbers that are actually going to talk about here, cited a few times both by proponents and opponents of Medicaid expansion. So I'd like to be able to place those in context and then look forward to answering any questions as well. KHI has been doing estimates of expansions since 2012. So predates my time at the Kansas Health Institute. Not quite every year, but almost every year. Have a very similar methodology over the years. However, it has been changed and adopted to reflect the experience in other states. So some of the things you heard from folks about experience of enrollment being higher than anticipated. So we tried to adjust our assessments and our assumptions accordingly. We also update our estimates when there's a provision in legislation that's a little different from year to year. So I'm going to be very high level. I'm just going to talk about our enrollment numbers and talk about some of the words you've heard before about crowd out, for example, and welcome mat effect. You've heard that cited a few times. I'll talk really briefly about sort of a cost over time. And then really even more briefly, but we'll point you to a resource, is characteristics of the expansion population. For example, how many folks are working, how many folks may have children in the home, et cetera. So I've probably used like 1 minute already just saying what I'm going to say, so I'll go ahead and do it real quickly. I included in your packet, you should have the issue brief, and there's an insert in the issue brief as well. There's also really long technical notes if you want to look at our methodology and how we've approached the issue, and there's a link as well to a longer memo that is the characteristics of the expansion population in Kansas. So our current estimate this year is that 152,000 new enrollees would enroll in Medicaid if expanded, but that number includes not just the newly eligible adults. KHI's estimates have always included the indirect effect of Medicaid expansion on currently eligible adults, for example, as well as children. And as has been noted, the Medicaid expansion, this legislation does not change eligibility for children. Nor does it change eligibility for other Medicaid adult populations, but it would, based on the experience in other states, likely impact the numbers who would enroll. So of our 152,000 new enrollees, 106,000 roughly are adults, age 1964, 45,000 roughly are children. Among that adult number, and this is some of the number you heard Senator she stepped away. Senator Gossage had referred to as well. So of that number, there are 66,000 we estimate. Oh my gosh, got 1 minute. All right, 66,000 who are currently uninsured. That number includes some folks that we anticipate we estimate had coverage during the continuous coverage period, but lost it in the unwinding, perhaps because their income fluctuated outside of the current eligibility limits. We also have about 1,800 currently uninsured adults who may be eligible for Medicaid but don't know it, so sort of that, or haven't enrolled, is better said, is a welcome mat effect. And then another 38,000 currently insured who might move to Medicaid if Medicaid were expanded. And that number is a number that would largely include those numbers from the marketplace that Senator Gossage referred to, between 100 and 138% of the federal poverty level. So that number is always inclusive of that number. Our children's number, again, they are all already eligible. Our cost estimates this year include a couple things. There are one thing that's new in the legislation, which is the hospital provider assessment, the surcharge. We look at a 10-year span, so it looks longer than your fiscal note does. So we start seeing the impact of that provider assessment or that hospital surcharge in 2027. And we also include the effect of the American Rescue Plan Act, that subsidy, that bonus payment, that incentive payment from the federal government that covers 2 years. So the total cost we estimate for the state over time, over 10 years, would be $680 million for in-state costs. If not for ARPA, the ARPA incentive is about $509 million, which if you saved that money up and said, hey, what's that going to be equivalent of cost of expansion over time, that would be about 8 years. However, states have also done things like North Carolina has done and decided to invest some of those ARPA savings elsewhere as well. And I will then, just because I was already told to wrap up, I will point to the other attachment that describes the characteristics of the Medicaid expansion population and those who are working and those who are not. Thank you very much.
Thank you, Carrie. Committee, are there questions for Carrie? Representative McDonald.
Hi, thank you, Madam Chair. I'm a big fan of your organization. I was kind of surprised to see you guys listed as neutral, given that 457 people submitted testimony in favor of this bill, and I think it was 12 people so far that have gotten an opponent testimony. But I wanted to ask you specifically about some economic development aspects. I've read in your documents that you gave us that it's that many industries and occupations will be most impacted by increasing the eligibility for Kansans. Can you talk a little bit about which sectors we could see job growth if we did do Medicaid expansion?
Which information are you referring to that we submitted? Because our most recent analysis hasn't looked at that. We had some analysis in 2021, perhaps, that was, yeah, there we go.
2021.
Okay, yeah. And so I'm sorry, I don't have that in front of me. We'd be very happy to share that with the committee. That was a research project where we looked at the likely industries that folks who would be eligible for Medicaid if expanded, what industries they currently work in. And so I don't have that in front of me, so I cannot answer that question, but I'd be very happy to share that information with the committee.
Just very quickly, if I can, it mentioned accommodations and food services, wholesale trade, healthcare and social assistance, educational services, which is a big interest of mine, and manufacturing. So I thought those would be important economic drivers in our state.
Right, and that analysis was looking at the number of folks who were employed in those industries who could be eligible for Medicaid if expanded.
All right, thank you so much.
My apologies for not knowing exactly where you're going.
All right, and then I've got one more for you, Carrie, which is Representative Reese.
Thank you, Carrie, for the testimony. If we were to expand Medicaid, what would be your estimate of the percentage of eligibles who are working? And then the second question is the same question, but would be of disabled people that would qualify.
So we had a discussion this morning in the Senate committee as well as about this, but included in the issue brief, there's a handout, but then there's the longer analysis that includes other characteristics. The analysis indicates that of the likely eligible adults who would be eligible for Medicaid if expanded, which would include folks who have current insurance as well as those who are uninsured, that about 70%, 68.9% of them are employed of the total, not just of the 68.9%, close to about 6 in 10 work about 20 hours, at least 20 hours a week. And then we have another set of numbers that's looking at the entire likely eligible population or just those who are not employed. And among those who are not employed, there are 38.5% who have a kid in the household. We look for these numbers because they are listed in the bill as exemptions for the work or community engagement requirement. So 38.5% had a child in the household who might then be potentially eligible for an exemption from a work requirement. 19.1% reported on the Census Bureau that they had a difficulty, and it's not the same as a Social Security SSI determined disability, but it indicates they have a physical disability or a cognitive disability, a eyesight or hearing disability, for example. The total percentage of those who are not employed, who might be eligible for Medicaid if expanded, who reported one of those difficulties, who potentially could be seeking a disability determination, as an earlier conferee said, for example, is about 19.1%. So that's of the subset, though, of those who are not working.
Thank you very much, Carrie. I appreciate it.
Thank you.
All right, committee, we're going to go back. I'm going to allow 15 minutes because we do have a committee coming in behind us here to open it up to questions. I do have for Sam, I've got Representative Blex.
Thank you, Madam Chair. Thank you, Sam. I think you made in your comment somewhere it's all or nothing. And if we expand Medicaid, there seems to be no pathway back. And as policymakers, I've been up here long enough to see some lean times when we had to increase taxes to cover our budget. We're certainly fat right now, but we're also responsible for being fair and sustainable. So when you say all or nothing, is there a path at all to get back off of it if decide we make a mistake or whatever?
Thank you, Representative. It's a good question. No, I don't think there's a path back. And there's a provision in this bill that says, you know, if the funding drops below 90%, by then you'll end Medicaid expansion. But if you go back through some of what the courts have said in the past, especially early on with Medicaid expansion, we're pretty skeptical that that would be allowed to happen. You're looking at a kind of a Hotel California situation on this. So I do think it is all or nothing, and that's why it's, I think, wise of this committee to do what you're doing and consider it very carefully. It's also all or nothing in the sense that there is not some state version of this. You know, I know you call your program CanCare, but Medicaid's run from Washington, D.C. You have very little ability to impact what this expansion looks like, and nowhere in Medicaid is it more true than with expansion. They have a very tight grip on what you can do in terms of eligibility checks, renewal periods, asset checks, other factors like that. So, yes, sir, I would say it's fair to say it's all or nothing.
Thank you, sir. Thank you, Madam Chair.
Next, Sam, for you, I have Representative Bryce.
Thank you, Madam Chair. Thank you, Sam. Just a quick question. It's related to that. I believe you said no off-ramp, basically. I'm a little confused, honestly. I hear conflicting reports on the work requirement possibility with Medicaid expansion. I think KDHE reported something that wanted to be done similar to the SNAP program. But I've heard that the federal government may not allow work requirements. I just wondered if you had a comment on that, how that interacts with the federal government. Thank you.
Sure. Thank you, Representative, for the question. So the current administration is on record against work requirements and beyond just Medicaid and other programs as well in various forms. The current administration is not going to approve a waiver to allow you to run a work requirement in your Medicaid program. They will not. They have fought those tooth and nail for the last, almost 4 years, and then before that as well. You need a waiver because there is nothing in current federal law that allows you to do it, of course, so you need to seek that special permission. The other issue is even if there's a future administration that might contemplate that waiver, and there were some granted under the Trump administration, how they're designed may leave you with something that is less than a work requirement, what you would call a work requirement, and is more like something North Carolina is describing, which is a voluntary job program they already had that they just kind of linked to the expansion. So if you're really looking for the type of solid work requirements that were passed in 1996, bipartisan at the federal level that you all have in your food stamp program, you're not going to get that here in the Medicaid program, and you most certainly will not get it anytime in the next year to 2 years.
Representative Vaughn.
Thank you, Madam Chair. Thank you. I had a question about your comments in regard to Section 4 of the bill. You say you have concerns about that section due to failures in states like Arkansas, New Hampshire, and Iowa. It is my understanding that their private options allowed folks who were eligible for Medicaid to actually enroll in the federal exchange instead of traditional Medicaid. But what's proposed in Section 4 of this bill is a premium assistance program. So I'm just kind of curious why you're comparing two different programs.
Yeah, thanks, Representative. They are the same program. It's the private option. It takes on different forms.
It's not a private option. It's a premium assistance program.
Sure. So it's a premium assistance names matter, obviously, as we discussed with the title of the bill. But premium assistance is the state helping the individual purchase their private insurance. paying for their premium. And this was, as I mentioned, it was tried initially by Iowa, New Hampshire, and Arkansas. What happened was the theory was that, we're going to do this in a more conservative way where, okay, we don't want folks on Medicaid, but we'll help them buy a private plan and it will be cheaper. And what happened was it was more than double the cost of even Medicaid. And insurers didn't, it wasn't a product the insurers wanted to be involved with. And so in New Hampshire and Iowa, I'm
sorry, Madam Chair, if I can. I think we're talking past each other because my understanding based on the bill that I have in front of me is that this portion of the bill is applicable to people who are eligible through their employer to receive health care, receive that, and then this would cover up to 2% of that premium, or that they would not be allowed to be charged more than 2% of that premium. So I think we're talking past each other. I want to end the question there. Thanks for your time. Thanks, Madam Chair.
All right, let's see, McDonald.
Thank you, Madam Chair.
I'm sorry, Representative McDonald, I apologize.
Thank you, Madam Chair. As a 20-year resident of Kansas, I had never heard of your organization before, so I did a quick Google search that told me that you are an out-of-state group, and I assume you don't live in Kansas, correct me if I'm wrong, who visited the State House previously to weigh in on banning soft drinks and candy for children to punish low-income, aging Kansans who are seeking food. And now today you're back, just one of 12 opponents, submitting testimony saying that we shouldn't debate Medicaid here in Kansas. In your testimony, you mentioned it's because we could end up with the same Medicaid expansion that New York and California have. My question for you, wouldn't you agree that as a Kansan, we're already paying for Medicaid expansion in New York and in California?
Well, thank you, Representative, for the question. And the bill to ban soda and candy from food stamps was also for adults, not just children. And yes, we did testify on that bill. So Kansas takes in more federal money than they send to D.C. So this is kind of one of the common things you'll hear with Medicaid expansion as well. We're sending our money to other states, and we should keep that home here in Kansas. But you're already a net receiver of federal money, and so that just isn't the case that you're paying for California and New York. Except, the caveat I would give you on that is, we have a $34 trillion deficit, and we're all paying for the mistakes of California and New York, and my kids will be, and probably their kids will be. And when you expand Medicaid, you're adding to that deficit. So really, no, there isn't Kansas money going to them that you could use here.
I think we're going to have to respectfully disagree, but thank you for answering my question.
Thank you.
Representative Gardner.
Thank you, Madam Chair. My question is back to this misappropriation of funds. It's been talked about today that the lowest number we've heard is 10% of funds in Medicaid are misappropriated. And I've read several reports nationally that say it's over 20. And I read an audit that came out in 19 that said Kansas rate was 27.8. But regardless of the numbers, it's obvious that there is a significant amount of misappropriation of funds. Now, if we were to expand Medicaid, is there any evidence that that number would improve or get worse? And if that is to be addressed, is there any precedent from other states that have expanded that have been able to improve that number, or is this a federal policy problem?
Thank you, Representative. Good question. So I used that number in a Senate committee earlier, 27.8%, which is the payment error rate measurement from 2019. And the department came up later and said that while the newer number is 7% from 2022. The reason why I believe that the 28% number to be more accurate, which means 28% of your payments in Medicaid right now are in error, or in 2019. The reason I used 2019, it was pre-COVID, And so during that COVID 3-year window, and we have not had a payment error measurement cycle that's been on the other side of COVID fully, the federal government didn't let you remove anyone from Medicaid. And they actually made you suspend all redeterminations. So any measurement, and by the way, most errors and fraud in the program are eligibility related. It's not someone stealing a card and taking it down the street, like maybe could happen in the food program or something. It's eligibility. It's gaining access when you're not actually eligible. And so during COVID, they didn't check any eligibility because you were required by federal law to keep everyone on the program. And so that more current rate is artificially suppressed based on that. I do believe the number, 28% is probably more accurate. In Ohio, it's 40%. So I guess you're doing better than Ohio, but they're both, really high, billion-dollar kind of problem. The issue with Medicaid expansion that I see that could make that worse is there are fewer checks. So in Medicaid expansion, that population, there's zero asset test, meaning you don't care what's in their bank account, you don't care what they own for real property, which, by the way, is not true for the truly needy on your program. Most of those folks have an asset test, but these able-bodied adults will have no asset test. And when you don't check things like a bank account, you don't find things like sources of income. And so we've seen in expansion states, Louisiana had a massive problem with this. At one point, 80% of their caseload was deemed likely ineligible by the federal government. You're not checking as much information, and so you have worse program integrity. States we've seen that have cleaned it up have done so through more frequent checks of data and making sure that they do verification on the front end when someone comes in to apply versus putting them on the program and then doing verification later. So those would be a couple things you could do really either way.
We'll see where we end up on time because we're running a clock over here. Okay, I think we're done with you for right now, Sam. And our next questions are for Christina, KDHE. You thought you were going to get by with no questions, didn't you? Yeah, we're not going to do that. Representative Reese, go ahead.
Thank you, Madam Chair. Heard a whole lot about fraud from the previous opponent, and I'd like for you to be able to speak on that, because I really would hate to have everybody be left with just hearing that side of what fraud might be out there.
Yeah, thank you for the question. So I would just respectfully disagree. I mean, would I say there's no fraud in Medicaid? Absolutely not. But I think to say that the 2022 audit was not relevant because we didn't do renewals, the vast majority of your perm audit is done on applications. People seeking coverage, not people staying on coverage. And so our percentage of cases that was polled was actually higher in 2022 than the 2019 audit. So to say that, well, you got to disregard a 6% or 7% rate and only take the 28% rate would be misleading. Now, I think what would be fair to say, we had two very, very different results, obviously. Now, I would say for those of you that have been in the legislature for quite a while, one of the big reasons in 2019 was the time period covered by that perm audit was back when we had the clearinghouse backlog, which I know some of you remember very, very well. And if you are untimely with your processing of an application, it's considered an error. And so I would argue that our rate was somewhat inflated. I'm not going to blame all of that on the 28.9%, but you'll also remember the legislative body here took significant action, and in 2019 you voted to take quality program away from a vendor and you put it back in with state staff so they could do the quality reviews of the eligibility program. And so I think what you saw in 22 was the start of some of the impact of some of the changes that the legislature made in response to some of the challenges that happened under a previous vendor that worked here in the state of Kansas.
Thank you.
Representative Clifford.
Thank you, Madam Chair. Thank you, Deputy Secretary, for your testimony. You mentioned 30% of folks on IDD wait lists are not currently on Medicaid. Is there wiggle room? I assume some of that's private insurance, family means, et cetera, but is there wiggle room either in current Medicaid or as you get a new HCBS waiver going to get more of those folks on Medicaid?
Yeah, so there our KDAD's partners right now are working on a community supports waiver with an opportunity to provide some additional supports to folks on the wait list. But yes, I mean, there are, even under the traditional Medicaid program, there are waiver options and other options available to increase eligibility. There's options for state-funded programs only to increase eligibility. So while not probably all great options, but yes, there are definitely options, and we'd be happy to share those with you if you'd like.
Thank you. Thank you, Madam Chair.
All right. Christina. On the rebates, what will those rebates total that we're going to shift to pay for this? What's the dollar amount on them?
And I am going to, if we start getting to budget, Dan, I am going to, are you meaning the surcharge?
The drug rebates?
Oh, drug rebates.
What's the dollar amount on the drug rebates to shift to this program? No, don't tell me you don't know.
Off the top of my head.
Oh, Will's got it. All right.
Yes. He always saves the day, don't you, Representative Carpenter? And you probably got that from us. Yes. Okay. Now I've got it in front of me. What's the question? Sorry about that.
So how much are the drug rebates that will go to this program?
So there, we're looking at here as I'm looking at the numbers that we put together. Let's see if I can read, and I should have my reading glasses with me, and of course I do not. Looks like it is about 2.2 million.
That's it?
For state general funds. Because when we do drug rebates, there's funds that have to go back. But looking here, and that's for a 6-month. Oh, that's just for the first year. So let me go down to 2026. It's 4.4 million.
And that's what we receive for the drug rebates?
That's what would be tied to the expansion funding. So the thing to keep in mind when we move to expansion is you're going to have our regular traditional program, which is going to have its funding streams and funding tied to it, and then you're going to have Medicaid expansion population, which is smaller, and obviously a healthier, overall healthier population. So total funding is going to be a combination of 2 different programs if we were to pass Medicaid expansion. So that's kind of where some of those nuances come in.
Well, I'm just trying to understand, Christina, how it is that we're going to take money from the drug rebates to help pay for this program, which means that we have to supplant that with SGF in the programs that are currently being paid for it. Would that be correct?
No, because the drug rebates will come in and be tied to, so if I get a drug rebate, and maybe I'm not understanding your question.
Our current drug rebate program.
Yes, and so if I'm a current recipient and I get a medication and there's a drug rebate tied to that, that is still tied to traditional Medicaid. And then if I have a Medicaid expansion member that gets a drug and there's a drug rebate tied to that, there's just the funding gets split as we move into Medicaid expansion. So we have to report to the federal government like they're 2 separate programs, even though it's all one Medicaid bucket. So the funding gets split out. So our eligibles will be reported differently. You'll have expansion population, non-expansion population. Expenditures are differently between expansion and non. It's just a kind of split because obviously we're going to claim 90% match for the expansion population. So that's why the reporting is so different. You're trying to keep the finances separate so we're not underbilling the feds or overbilling the feds if you were to overbill them for a non-expansion person.
Representative Carpenter, am I missing something in my question? Nope, you're going to stay out of that one. All right. I think maybe we just need to visit on that.
Yes, yeah, because I
perhaps.
may be misunderstanding
And
what
then
you're asking me, which is
Can you tell
true.
me what you think 6% of our Medicaid program is today? What would 6% of our Medicaid program be?
Eligibles or expenditures?
Expenditures.
Oh, boy, you're going to make me do math in my head. So I'm going to ask
Well, I hope
Dan.
you brought
He's got a
people that
he's
have
got
that
a
math
calculator.
that can do it rather quick.
Yes, because you remember in Bethel that time, someone asked me a question to do 20% in my head, and I was like, oh, boy.
Well, while they're working on that,
Okay.
then if I understand, it correctly, we're adding a new hospital tax?
A surcharge, yes, after 2
Well,
years.
tax, surcharge, whatever it is, it's all the
Yes.
same.
Yes.
And how much is that?
There's a funding formula in the bill. It is so much per Medicaid expansion member. And I don't remember which page it's on, but there's a formula for it.
So who pays that? Is that the hospitals?
The hospitals
Or
pay
will
that.
it be the consumer because the hospital puts that on their bill to pay for it?
The hospitals will pay, the hospitals will pay. Now, we've worked with the Kansas Hospital Association already on the surcharge to look at would it be a net benefit, and this is before the 6% that's being proposed, but under the current HCAP program, if you take all the funding streams in and you take in Medicaid expansion and then also take away this surcharge, they're still net to the good of about $187 million. 280 million is 6%.
Okay, I'll have to look at those numbers. So, committee, we are up against our hard stop here. So, Christina, thank you very much.
Yes,
I
thank you.
appreciate it. Carrie, I did want to make a comment that I've actually heard people use your information both as proponents and opponents. So I would say that your numbers are pretty fair on some things. So we appreciate that. Committee, we are adjourned until 1:30 tomorrow.